am Ira Kirschenbaum. I am actually on the streets of Yonkers, New York, um, but that's the noise in the background. We have a great article today and a great group of people to present it. Um, I will share my screen right now and show that article. Um, Let me just do that. Um, this is Joey, of course. Um, Here it is: Virtual Reality in Medicine, a systematic review of current applications of VR and potential applications to pediatric orthopedic surgery. So I'm going to start off. I'm going to ask Jessica, because you're the lead author here. What was the impetus for this study? What for this review? What was on your minds, and what did you think you were going to find?
Yeah, that's a great question. So Nate and I worked really closely together on this project, and it was actually something we came up with just sitting around one day talking about different ideas. We're both working on our own individual thesis for medical school, and we kind of came up with this idea. I was working in pediatrics, he was working with virtual reality, so we said, wouldn't it be interesting if we could combine these two ideas that we were working on? So as we kind of talked more about it and talked about kind of where pain management in pediatrics was going, and just the new technology that's out there, we figured, okay, we obviously need to learn more about what's going on and how it's being used and how it can be used, because we had both had clinical experience that said, you know, there are these things happening, but we can make them better with this new technology that's becoming more accessible and more prevalent. So that's kind of where we went with this. In terms of what we thought we would find, we honestly weren't sure. We kind of went into it with kind of fresh, clear eyes of let's just see what we find and go from there. And Nate, if you want to add anything, please do.
Nate, you got something there?
Yeah, my connection is a little unstable, so I apologize if anyone can't hear me. Um, but yeah, so actually, funny that we talked a little bit about Precision OS, and I understand the founders on the call. I had been working on a couple of studies that Guy Singer's looked at with Precision OS, um, and both of the studies that we were doing were targeted towards an older population. It was pain control and modulation after total knee replacements. And when Jess and I were trying to find a good intersection to work together on a pediatric study, one of the things that we brought up was virtual reality is something that I think kids are going to do so much better with than our older population, because you just see them in front of their screens all day long, every day. You know what I mean? I see how many patients have you seen in your clinic where the 7-year-old is teaching their mom how to use their iPhone? And you got a toddler before they can walk that can unlock their iPad. It translates over into all the different types of tech. So we were finding really great efficacy in older populations with pain relief, as a VR as a modality for pain relief. And I said, boy, maybe we'd find even better if we use it with kids, because they're going to be way less apprehensive. They're going to be a lot more eager to slap a headset on themselves and try it out. And we looked over at the cast room, and I'm sure everyone on this call can speak to how tough it can be for a kid in the cast room with the loud noises and the screaming and the crying. It's just a nightmare of an experience for them. And every institution has a different way of approaching it. We have earmuffs in the cast room at my current institution. Some of them will have an iPad that the kids will be used to distractor, but um, never a perfect modality. And that's kind of where the idea came from. We said, well, what if you slap a headset on the kid a few minutes before you start taking their cast off, and see if you can really get a great distractor, so that the noise is away, and they're not seeing a saw, and they're not seeing their parents. The parents always look concerned, um, and kind of the first step to everything that we've done with Dr. Seeley, and to his credit, he's been such a great mentor for us, is if you have a project idea, you better know damn well what you're talking about. So first step is do a literature review. we did a literature review and we actually found that there was a pretty big gap with respect to this stuff in pediatric orthopedics. The first literature review was scoping. And then over the holidays, I think maybe a year or 2 years ago, we said, I think there's enough here for a systematic review. We can point out a gap. And that's as good of a summary as I think I can give you. I hope my connection stayed stable.
Oh, it was great. It was really great. What I thought was very interesting, we we go to meetings, the academy and elsewhere, and we see a number of VR companies, and they're all talking about the idea of using it for surgical simulation, surgical training, anatomic training. But what I thought interesting, what you guys were looking at, was the patient side of using virtual reality. Have you looked at it in, Mark, could you make a few comments about that? The idea of flipping it from training residents and training fellows and medical students to patient applications.
Absolutely. And I think Nate kind of laid out, this was kind of the first step of several other projects that are ongoing and kind of rolling out. At the end of the day, I'm always just looking at how to distract kids, whether it be in my household and or clinic, because I find when the kids are distracted, my life's a lot better. But from an application standpoint, the patient experience is different. And I think this is where, Danny's been like doing such a phenomenal job from an educational side. There is an immersive virtual reality for kids makes it less intimidating. And I think there is no doubt in our careers or over the next 20 years, when you go into a pediatric waiting room, this will be very dome related as far as kind of the walls will be changing. A lot of places are already doing this where it's interactive and it's not white walls and extremely intimidating. That is going to target the patient experience, but there is a benefit on our side of just kind of making the job more seamless and then just kind of decreasing the pain side of things. Because whenever you have an anxious patient, the risk of a procedure you're doing in clinic goes up, whether it's taking a cast off, pulling a pin, or doing some type of lump and bump removal if you do them in clinic. I mean, all that you need a calmer patient to do that with. So what I'm actually very interested in, I think, Danny and others have kind of been targeting, is just like what's actually going on up at the top. There is the kind of some neuromodulation research that's going on with like fMRI with virtual reality, and it's like showing promising, effects. So there's things that are going on that are just more involved than just like distraction. So there is something that's to this. And I think, the UCS group and Children's Los Angeles are doing some really cool stuff with just looking how this is impacting someone. And it's not a simple distraction tool. It actually is having some type of, neurochemical change in the child, and it's just whether it's long term is a whole thing in and of itself. So
do you save a lot of money on lollipops and candy and ice cream in the clinic, I guess, right, Mark?
Well, absolutely. I mean, I think in some of the studies that Nate and Jess kind of reviewed, the patient experience is better, and I will tell you, from when you do this anecdotally, the families are just, they see you trying to be proactive. And, the question is does a VR headset versus like an iPad, does it change? I think it's a little bit more cutting edge. And, as VR kind of evolves, it's really, cool to put them in a different place, and you can't do that with an iPad just because your peripheral vision is constantly scanning the room. So I think there are definitely things where I think there's going to be a lot of room for improvement is going to be with the younger, like less than 5. Having tried to do, VR on 3-year-olds, it's just the headset is just too bulky. So there has to be something else. And I know people are coming up with different ways. It's just going to be, the next step of evolution of VR to target that age group is really what needs to happen.
I think it's great. Anyone else have any other comments or questions right now? I don't want to dominate. I have a whole list of questions.
I'd like to throw one in if you don't mind.
Yeah, please,
You know,
Mark.
this is really interesting because years ago, when I was first starting in medicine, I did some work with a company called Steelcase out of Grand Rapids. They mostly do furniture and stuff, but they took a small hospital and on the hallway ceiling to the ORs, they painted a cartoon story. And the orderlies and nurses were taught to tell the children that story as they wheeled them to the OR. And they found a statistical reduction in the amount of drugs and anesthesia that it took to anesthetize those kids. So I think it even would have a cool application there. I'd never thought about it from a patient standpoint.
You know, this, oh, sorry. It might be getting a little off topic, but once again, Nicole Maurer out at the Children's Los Angeles is just looking at the chronic pain. So when you're going and doing like a pediatric, you know, most of my patients get better, but there are certain procedures that you are doing that has the potential to end up in a chronic pain pathway. And they're looking at, is there a way of kind of, you know, setting the person up for that status going into the operating room that can kind of change that? And I think it's just a really cool way of, you know, thinking about it versus just hitting them with more drugs. So,
You know, I think this also speaks to a lot of things we don't know about what is happening in the brain, whether it's through looking at PET scans, looking at serotonin levels, looking at endorphin levels. I mean, something is happening, and there could be great applications in the post-operative experience as well. I mean, what do you guys think about that? You know, thinking about post-op rehab and pain, you know, diminishing pain, you know, adding, you know, maybe better than adding Celebrex, you know. I mean, it's something of that nature, you know, doing an entire post-operative module on combination of education, fear reduction, meditation, relaxation. I mean, what are your thoughts about that, guys?
you know, Nate, I don't want to steal your thunder. I don't know if it's been published data, but this was one of Nate's projects of in total joint patients of in the post-operative period, slapping a VR headset. And I think what were you doing? Put him on a beach, Nate?
Yes, sir. Yeah. We were looking at TKA patients. So we gave them the patented lifetime warranty Dr. Michael Sook total knee replacement. And then, wait, there's more. We gave them a beach experience for their post-operative recovery timeline where they were logging hours on their headset. And, you know, I won't give away the ending, but a lot of what we've seen, and the study is still ongoing, is kind of to the point that Dr. Nichols made. They're using their standard of care post-operative analgesia less. Their patient-reported outcome measures with some of the instruments that we're using are better. And this again is in a cohort of older people. So now you think about the applications across the age spectrum, and I can tell you when we were enrolling people, a lot of them were apprehensive and didn't want to try it, and they didn't really buy into it. I'm not a neuroscientist. I don't know a lot about fMRI. I have seen this stuff before about how it is a little bit better than a distractor, if not a lot better than a distractor. But I can tell you that anecdotally, and N equals one in the way I feel about it, someone who's less apprehensive, I think, is going to get more utility out of it. And I think you're going to find less apprehension and more acceptance the younger you go.
What are the kids watching when you're taking their cast off or taking their pins out? What's actually on the VR?
Yeah, so there's a couple different things. So, you know, when you talk about VR, you have role play games, right? So that's actually better for your teenagers. So I have an Iron Man game that I'll have them go and like fly around on. And then the littler kids, it's more immersion. So you put them in a scenario, and you know they're looking at like, you know, a waterfall, or they're looking at a flower bloom in front of their face. That's kind of, you know, cool. And I think it's just more kind of targeting the age specific things. But there's probably better ways. And, you know, I would love to send a VR headset home to my patients that are going to go through a surgery and have them go through what the day is like preoperatively, and you know, then to try to calm down their nerves. Right now, we send them home with a PowerPoint, but like, let's put them in the situation that is not as intimidating, and have them have familiar faces that introduce themselves the day before, the week before, just to go through things. So, you know, I think there's just so many ways you could go with this, that is just like kind of cool.
But are they actually they're just watching? They're not doing any manipulating, any kind of control. They're what they're seeing, or are they just doing that as well?
So it depends on, so, you know, if I'm taking off a lower extremity cast, you know, the whole plane of game, you're using your arms, you know, so you're playing the game. You're just not walking around. The littler kids are, you know, you can reach out and touch with the controller, so you define your boundary. And I think that's some of the more clunky part of it, is you have to set that up every time. So from a patient flow standpoint, you know, you're probably going to have to set aside 10 minutes for that patient versus a 5-minute visit. So it's a little bit more, or you have a child life expert that is doing it for you. So, but it is interactive. They're not just sitting there. You know, the little kids are reaching out and touching the flower and whatnot.
You know, I was thinking, I just want to put Danny Goel on the spot here on this and say, you know, I've been involved in episodic care management companies, and I kind of think that maybe VR can replace so many of these episodic care management programs, whether it's Zimmer, My Mobility, or even SwiftPath, which I helped start. You know, you know, think of connecting real time, maybe even to other patients in the surgical experience. Danny, have you guys thought about that in Precision OS?
Yeah, before I answer, I think Kevin Plancher had his hand up.
Oh, I did not see that. Kevin.
Yeah.
Yes.
No, that good afternoon. Sorry for the delay, Ira. I'm not as provocative as that, Ira. I was curious for Mark. Is this because PAs and nurse practitioners are doing more interventions and the doctor's too busy? Because I've watched a lot of mentors talk people through things amazingly, but I'm not understanding is where a PA would not have that same compassion or empathy in doing the procedure. So do you feel, Mark, that's why this is a big role for you, or you find even for yourself that it's having? I'm trying to really grasp the lack of, I don't see a 13-year-old having a problem cutting a cast or taking a pin off, or a total knee patient, if I'm the one explaining the whole procedure.
Yeah, no, I think that's you know, really a thoughtful question. I will say, Dr. Plancher, a lot of this started after you came and gave grand rounds, and you mentioned patient experience and all that stuff. So you do have a kind of role in all of this. But you know, so I think the component of anxiety is like, I mean, I think if you take care of, it's like picking and choosing your battles and picking your patients. Does every teenager need it? Absolutely not. But you know, with anxiety, fear, all that, it's like, who can you pick, who's going to throw the curveball? And you know, right now I'm doing my patient reported outcomes and a lot of the screening before they enter clinic, so that I hopefully have a better understanding of who that anxiety patient is when they walk through the door. So approaching them, if I can get those pins out quickly and get them out of the door and get them on their way, absolutely. But, you know, as someone, I don't know what's going on, but I feel like my clinics more and more, I'm seeing, you know, chronic pain in kids. And it's like, this was like unheard of, you know, 10 years ago. And it's like, what is going on? And, you know, there's definitely a component of other stuff in the atmosphere. I'll blame COVID. I don't know, but
Right.
there's something that trying to predict who that person is. Yes, I can try to coach them through it, but sometimes just getting them out of that situation is what you got to do, and
Thank you.
that's what you're doing.
Thank you. It's great to see you.
Good to see you too.
Right. Danny, I'm going to put you on the spot again about are any modules dealing with episodes of care management in the works?
Yeah, so I'll start off by saying, congratulations to Dr. Seeley and team for the paper they published. It's a really, really big and exciting area using VR for this patient engagement piece. And I think it's summarized well with the term that was used earlier, which is patient engagement. And the one thing that we've observed is, and I think everybody on the call who's an orthopedic surgeon that sees patients is, if Dr. Plancher is explaining a need, they'll never tell him that they don't understand. And so we don't know which patient understands and which patient doesn't. And that directly is correlated with their level of anxiety about the procedure. And so, I do just shoulder. So when I explain that I'm stapling their tendon to bone, I don't know if they know what that means. And so that directly impacts their anxiety. And so VR has a role to play in education of a particular procedure from the beginning, as Dr. Seeley mentioned, all the way to the end. The things that we know that are different between kids and adults is they both perceive pain very differently. So adults signal pain very differently than pediatric patients do. And the impact of VR is an attempt to trigger those different neural pathways. And they don't understand it very well just yet to say why it actually works. The one thing that we do know about VR is that it's not just distraction, it's active engagement, completely active engagement. So they can't do anything else besides participate in VR. And one of the apps I tried as for interest was this meditation app. And I was truly immersed and able to meditate in a meditation app because I couldn't do anything else. I couldn't think, I couldn't text, I couldn't talk to anybody. The one thing that we do know that we're following, and we don't know the impact of this, is kids under the age of 10, they pose the VR as somewhat of a risk for prolonged use. So we don't know how long it is. And Dr. Seeley, I'm sure you came across this because it can affect their ability to accommodate with their eyes. So that's something we're watching in terms of the maximum amount of time. What's the clinically relevant amount of time that they should engage with VR before there's other issues that we may open ourselves up to as surgeons recommending VR either before or after the surgery. Or in the case of pediatrics, taking a cast off. I think small intermittent doses are okay. The last point, Ara, directly to answer your question, we are looking at this total care sort of approach from beginning to end with virtual reality and how best to sort of institute that.
It's great. It's great. I don't know if there's any other hands up. Let me just look.
Well, I think just to make one comment, and I agree with the headset, it does have some, definitely some gray area with that. And I think that's where like the dome screens and just getting stuff off of this is going to be probably, it's more immersive than having an iPad, but it's not kind of, I don't know, secluding the periphery. Like you're still having that peripheral vision. I think that's where the interactive, atmosphere of, walking into a room and having everything kind of interactive is probably a way of having that immersive virtual reality component to things. So,
I think, and Mark, Jessica, and Nate, maybe you can comment on this too, is that, I have lectured on the idea that I actually have problems with patient-reported outcomes. I think patients are not very engaged. They get a text message at a odd time of the day to fill out some questions that were written by 3 Ivy League graduates and doesn't really work well in the South Bronx. But there's a term that we use at a company that I'm part of, Gate Science, patient source outcomes, and where we're really getting natural patient responses to whether they're satisfied with something. And I think you can possibly do that in kids. I was wondering, Jessica or Nate or Mark, whether you thought you can work on an outcomes module as well, not just to alleviate their fear, but really get information through indirect ways in VR to replace patient-reported outcomes, which I think are what we have now. Don't get me wrong, they are what we have, but I think they're very limited, and they only work well for the insurance companies. So
I don't have an answer for this, but I think kind of what Danny was talking about is like, is there a way of rolling this up into a fully inclusive thing? Just like what Precision OS has been trying to do with kind of retention of the learning environment of a procedure, right? That there is a component of retention of what we start out with. Do they understand the process, and are they getting this? So I think there is probably a way of doing that, and I don't know if you're ever going to fill a questionnaire off on it, but there's probably ways of doing some form of module, consistent modules, just like you do your physical therapy. You're doing this to just provide that real-time feedback on a platform. So,
what are the interesting things you found during this whole analysis of where this is going? Okay. Is there anything that we have missed so far? What's the real future of this? And explain more about what you call the dome, effect.
Yeah, no, I think it's going to continue. I think as the platforms or the technology advances, like I don't think we're always going to be wearing that headset, and Danny could probably elaborate more on that. I think that's going to continue to evolve, and I think it's going to be something you can do quickly, just like you can throw an iPad here. There's a little bit more setup.
Right.
But the dome screen is just like, it's essentially, you've all walked into an IMAX movie theater where everything around you is an immersive virtual reality, and so I think that's a way to tackle little kids, and I think that's making a traditional clinic room a little bit more tolerable. It's just very expensive. But maybe it's a procedure room in the future. Who knows? But I think just kind of what we're talking about with continuing doing something like this throughout a patient's stay, or a patient's progress, I think that's going to be stuff that we can do, and I think it will be a way to check, in on a patient, whether it's through the metaverse or whatever. But I think there are opportunities that we have not fully exhausted. And I think I'm excited to see where this goes over the next 5-10 years. I think it's going to continue to evolve.
I think there may be a role for some of the residents to get up off their chairs and from the computer and actually get into the VR headset and talk to the patients once in a while. That's my little dig on the residents in front of the computer all day. But I think this has really been such an exciting area. When we invested in the Precision OS, we didn't know what to expect, and it really kind of blew us away. And we're just scratching the surface of this. I'd like to hear a little bit more from Jessica and Nate about some other applications that are in the works, if you have any.
I found the most interesting piece of our entire review that I wrote, and I hope you'll forgive me for diverging from orthopedics just for a second, was the neuropsychology. There's a really interesting paper, two interesting papers actually, that they used virtual reality to help kids One, kids with eating disorders to kind of coach them through a better body image. And the other one, so that, yeah, that one was a therapeutic kind of use case for the headset. And the other one was diagnostic. Neuropsychologists used it as an evaluative tool for kids with attention deficit disorders because it's a really fine-tuned way of watching, how their eyes work, and the eyes being the window to the brain and all that type of stuff. Those were the two outside orthopedics I found to be the absolute most interesting. Um, Anecdotal use case that I find interesting, reductions in the emergency room. I just saw one the other day, and I think it's par for the course, depending on the institution you're at. If you've got a tricky reduction, if the kid's nervous, it's pretty commonplace, at least where I've been, for a couple of squirts of fentanyl up their nose. I think that's a great avenue in the future for a headset as an alternative. Um, and then I think that the last point I wanted to make was to circle back to your outcome measures. And I
Yeah.
agree wholeheartedly that the patient-reported outcome measures, the instruments we have today, I have a research role this year. I'm administering them myself. I mean, these kids' eyes glaze over. They're reading the questions we write, and there's just a disconnect. And you're right, they're not invested from the start because you're approaching them at a weird time, and then they're reading something that really might not be, targeted specific to them. It's really more targeted towards our colleagues when we report them in our papers. Um, the trouble is, though, I think you have to speak the language first of medicine and what medicine has been. Um, Experiences we've had in the past is if we don't have the patient reported outcome measures that people are looking for, they tend not to pay too much attention to us. So kind of the middle ground that we've looked at for future VR studies here is some of the simpler, like the visual analog scale, for example. Everybody
Right.
knows the face. Everyone knows the faces. That's a pretty good way to capture kids' pain. There's one for pain, there's one for anxiety, there's one for fear. There's no reason why we can't, aggregate those into a composite satisfaction score for kids. It's not perfect. It wouldn't be in the headset like you're suggesting, which I think is a great idea. But it's much better than a 52 question survey with a paragraph per question.
Right. I think so. Mark, what are your thoughts about that? What Nature said?
I love it. I struggle every day getting my patient report outcomes, so it's got to be simple.
Yeah.
You know, so I think it's kind of finding that the sweet spot. But I love just faces or thumbs up, thumbs down, all that. There you go. That's all we'll take.
I think I was so excited to publish this article because of its push on the patient side, and rather on the procedural side. And I really commend all of you for getting that angle. And I think this article, in a lot of ways, opens the door tremendously to research and opportunity in looking at patient-based medical applications in BVR. It is, in some sense, it's easy to I'm not easy. I don't mean to say that. It's an easy jump to say, let's teach someone anatomy. But it's a harder jump to say, let's decrease fear of a child who's going to go through a hernia operation or through a a scoliosis operation. We talked about pins and casts, imagine scoli operations, and really delving into that, and getting that interaction with the kids on such a high level. So I really commend you guys on opening the door in a sense to this. Obviously there are a number of articles on it, but they were kind of all over the place, and I think your group put this together beautifully. And I want to thank you for publishing it in Joey.
I think if we look 10 years forward from now, This is just touching the surface. And the reason on a Wednesday night you have such good audience participation is because we're going to look at this now in the same way that anesthesia looks at ether for anesthesia many years ago. It is going to be much more specific. It's going to be much more exact. It's going to be less addictive, and it's going to be the norm, not the exception. And it's going to just expand. So this is just the very, very genesis of this all, but it's going to continue to expand. And I think that's why it's so exciting.
I agree. So, if there's any other questions, we'll take them now. Otherwise, we'll call it a night.